This is Sg2 Perspectives, a conversation with industry experts and Sg2 thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
We're trying to build a scenario about how this plays out for us over what time frame, what can we expect to regain in revenue and contribution margin, and how quickly.
Welcome to Sg2 Perspectives. I'm your host, Trevor Durin. Today I have the privilege of talking with both Sg2's own Bill Woodson, as well as our former CEO, Steve Lefar, who's now the executive director of the data science group at Strata Decision Technologies. Today we're going to get Bill and Steve's insights on how the health systems that we work with need to balance between near and long-term considerations as they think about the financial impacts of COVID-19. And Steve, we'll start with you because while Sg2 spent a lot of time in the last few weeks building our COVID-19 surge demand calculator, which really impressive. It's available publicly. We'll link in the show notes to those of you who haven't seen it. But we built a demand calculator because that's what we do best, forecast demand. But Steve, at Strata, you built a model using a proxy patient to determine the financial impact of COVID-19 on U.S. hospitals. That's exciting. Please give us the highlights. What are you predicting?
What we saw, we looked at Italy and China, looked at the kinds of patients they were seeing, and came up with what we called the COVID proxy patient, for lack of a better term. Falls into about 8 different DRGs, ranging from pneumonia with complications all the way through to ECMO ventilator support. Looked at what similar patients to that looked like in the same time period by DRG. What were the payments? What were the costs associated with them? Made some estimates about what the increased costs would be based on what we were hearing from clients about nurse staffing ratios and things like that. Bottom line, even with the 20% bump in DRG payments that the Congress just passed in the stimulus bill, it's going to fall short for most every provider. We had looked at 38 health systems that kind of had pristine data ranging from large, mega large to small, regionally diverse. And on average, with that 20% and about a 25% assumption on cost increase, they're still losing about $1,200 a case, but the range in that is up north of $6,000 to $8,000 of a loss. And that's assuming that they're full of COVID patients, human tragedy, but having those patients fill in does provide some contribution margin, even if they're losing, while people are waiting for COVID patients and have emptied out all of their electives and schedules. And we can talk a bit about how that's not sustainable either, because a lot of that's oncology and cardiology. They're losing even more. So this is, despite the congressional efforts, which were valiant to get funding to the providers on a DRG payment basis, it's woefully inadequate. We think it needs to be about a 35 to 40% bump in pay. And our clients are reporting volumes and revenues down north of 50%, and it's really, really difficult.
So, Bill, how are strategy teams being asked to use new inputs like this great tool to plan for the near term and potentially the recovery?
There's certainly a bifurcation, or there's a mindset or varied mindsets within our health system members. There's an all-hands-on-deck approach to providing care at the front lines. There are systems that have furloughed employees as they just dedicate all the resources to their intensive care needs, vents, and med-surg patients. For those systems who have planning teams engaged right now, they've been tasked with thinking through the recovery. What's it going to look like? How fast can we get there? And on the top of the list is how quickly can we resume performing elective procedures? And that is a multifaceted challenge because it involves facility issues, perhaps how you partner with ambulatory surgery centers in your community more robustly. There are supply chain issues that will reverberate beyond COVID. There's things with anesthesiologists. There is which service lines get certain preference, block schedules, and then most importantly, patient safety and employee safety. When is going to be the right time to come in to get one of these elective procedures? How long would you put it off? Do you have the financial means to pay for it? It's not easy, but we've certainly seen kind of requests from our members this week saying, hey, we're trying to build a scenario about how this plays out for us over what time frame. What can we expect to regain in revenue and contribution margin, and how quickly? Steve alluded to the immediate financial consequences of this crisis. That adds to the urgency of getting business back. Can we keep the market share we had? Can we find a means to get back in business or business as usual? And what we're trying to tell people right now is we don't know exactly when that's going to be, but don't expect a V-shaped curve. It's going to be a multi-phase recovery.
One thing to add to that, what we're hearing from our clients is in the quest to empty the beds, try and keep everybody safe, that they would love to be able to open back up, because a lot of what's been canceled, if it's canceled too long, is going to lead towards worse outcomes for many patients. They're canceling cancer surgeries. They're canceling things like ablations and valve work and things that are actually pretty critical. When we can get point of care testing ramped up and they can check everybody in the morning, check the patients, deal with the safety issues. Bill, you raise a good point about the payer issues. If people are now on unemployment or on other kinds of insurance, some of those cases may not be the kind of margin that they used to be. But what's being deemed or called electives are often scheduled and pretty critical. Some of the physicians we're talking to and some of the organizations that are thinking about how to model this, if they can keep people at home and have the volumes be lower. You're seeing that in Chicago, where they've tried to designate facilities as their COVID facilities in the hopes that they can open up quickly their other facilities, because some of this stuff can't wait that long and we're going to end up creating another problem for those patients.
Yeah, Steve, you're right. The term elective maybe isn't perfect to characterize all the things that are waiting because of COVID. That's a great point. So, Steve, maybe connect the dots a little further. Planning teams are trying to have a plan in place so they're ready when, I won't say things return to normal, but they return to treating non-COVID patients again. What about finance and operational leaders? How are they preparing?
In a matter of 2 weeks, everybody's budgets just became mostly useless. And so what we are seeing everybody do, it is all finance hands on deck, rebudgeting, reallocating cases, figuring out how to redeploy labor. What are they going to spend money on? What are they not going to spend money on? What capital projects can go on hold? It is a complete remodel of all their financial systems, and Strata serves about 220 health systems, and we provide full financial applications from forecasting, financial forecasting, planning, budgeting, anything a CFO might need. And we're seeing every day, all day, work for our teams and helping our clients make sense of this in their own data, and even begin to look at flexible budgeting approaches where they're not even trying to forecast it, but just flex day by day based on more of a KPI driven budgeting process so they can make heads or tails of this. It is pretty difficult right now modeling in the kinds of telehealth growth that SG2 was forecasting years ago. Now it is blown through probably everybody's projections. You're seeing large health systems go from 50 visits a day to 5,000 visits a day, virtually hospital at home taking off. So everybody's trying to model the financial implications. And then, of course, downstream from that, do we have to furlough? Can we tap our lines of credit? Do we need to borrow money? What does the stimulus look like? So it's one of the more, if it wasn't due to such a tragedy in a pandemic, it's one of the more fascinating times to be in healthcare finance.
Steve, the strategy people aren't as focused probably on liquidity and rapid budget evolution as the finance teams are, but they're certainly digging back into capital allocation, near term, long term. There is some work already underway around service distribution, what services should be at which facilities and locations across our system, what capital can we invest now, what's a sensible use, what's an ROI. I think that all of that's going to be upended to a certain extent, and maybe that is a bit of a silver lining out of this, because a lot of those decisions had fraught political issues around them, consequences. I think there's a willingness to dig in now to say, all right, what do we solve for over the next couple of years to preserve our capital and be intelligent and recognize that we're going to adjust to a new market reality beyond that recovery. There's kind of a healthcare next philosophy that we will be encouraging and hope evolves over the next several months.
Bill, it's a great point. The discussion that will end up being had longer term, I call it late this year, and particularly in an election year still, is can we allow this subsidization from commercial to government, from cutting and sewing procedures to taking care of people medically like we're seeing now? And it's this whole situation is laying bare just the irrationality of, even in a fee for service model, how this works. And I think it's also going to open up a whole discussion about value based care and who really is going to be capable of taking the risk, right? None of the hospitals can take the risk. We'll see if the payers can take the risk. The federal government's trying to deal with it in these situations. People who we haven't even heard yet, people who have full global risk on the provider side for these patients, how's this going to play out for them? So I think there'll be a lot of questions long term for the strategists working with their finance and contracting folks to say, what does this really mean when we know these things can completely blow up the system?
We don't have a complete answer to this yet. We've been debating it internally, Steve. What does this mean for the future of fee-for-service versus other payment models? What is clear is that we've had a failure of our public health system or our public health infrastructure. And therefore, coming out of this, we're going to expect health systems across the country to be more closely connected to what those needs are, what services are provided. That will get in the near term into surveillance and testing and monitoring and contact tracing. This is uncharted territory for us, even as we think about the future payment environment. And then the issue that got raised to me just a couple of days ago was, all right, let's say elective procedures are back. Will the payers be able to grant us pre-authorization as quickly as we want it to get patients in the door? There's a lot to work through in the next, let's call it 90 days.
Now, Steve, some of the boards you're on probably give you great visibility into how payers are thinking about this. How should our members be thinking about their relationships with payers now?
Certainly in the near term, the payers are adding a little bit of confusion. It's been great to see them step up and waive copays and deductibles and make sure that things are going to be paid for COVID members. You've seen some of the big payers do that, but there's absolute chaos in what telehealth codes to use, what codes to use for COVID patients, how to deal with this. So in the near term, I think the client base trying to put pressure on the payers or work with the payers to give unequivocal guidance, even across payers, have them agree for those of the clients that have really good relationships with the payers, getting the billing and reimbursement folks clear guidance on what to do here is critical. On the near term, having the discussion that Bill just mentioned about, okay, when we get ready, a lot of these procedures that are prior auth, they're urgent. We can't wait 2 or 3 weeks more to get prior auth. And how do we make sure that everything is teed up, that there's some interim set of rules so that if there are windows of opportunity where they can take care of a patient, say, needing a cancer surgery that's been put off, or imaging work that's needed to be done as a follow-up, that those things can be done. So being very proactive in working with the payers so that when we start to come out of this, which inevitably we will, and if this goes on too long, those cases still need to be done somewhere. So getting that approval and reimbursement policy in place for what we're going to do for these patients. The other thing that I'm seeing, and nobody really knows how this is going to play out yet, you've got people in this window that are going to be unemployed. And so they were insured, and there may be claims that have been put in or will be put in, this issue over who owned coverage. And are people going to be on Medicaid, or are they going to be left on COBRA? How all that's going to play out. I've heard a couple of providers express real concern that they're going to all think people were covered, and then they're going to find out later that the person had actually been laid off or unemployed or was in the middle and didn't have coverage, and it's going to create a bad debt bomb for the providers. Hopefully that can be avoided, and there'll be a lot of work between the payers and providers about how to make sure that we're taking care of people during this period of time. Personally, would love to see a Medicare opt-in or the ACA exchanges open back up for everybody easily and quickly, but it does not appear that's going to happen for those, sounds like 40% of people that have been put out of work.
Steve, we want to encourage health systems to start having conversations with the brokers in their market and think about the open enrollment period. this fall. Is there an opportunity for direct employer relationships or narrow networks or tiered networks that was not there before? Just given what the premium structure might look like, there may be a different way to go to market than what existed 12 months ago or 6 months ago.
So far today, we've mostly talked about how hospitals are adapting planning, but what about independent providers? They're feeling really significant stress right now, obviously with variability based on specialty. What might some of the impacts on independent providers be down the road?
So hit that at a couple of levels. The providers that have relationships with independents, I think there's also an interesting discussion about for-profits and private equity that have entered into the physician management space and where that's going. For the local providers, certainly trying to help those providers continue to stay open, continue to stay in business. It's a matter of supporting the community, enabling them with technology. There have been a lot of waivers of rules for whether it be HIPAA, whether it be fraud and abuse here, trying to take advantage of how do you help people get healthcare on a continued basis for those independent physicians. I think there's also going to be a discussion in the large health systems about we've bought all these medical groups, all these practices. A lot of those physicians are risking their lives to come to the front lines and leave their practices. Sort of what's the relationship going to be long term and how do we support each other? Some of these physicians are really taking some dramatic cuts in their practice and are now sort of helping out with the facility side. One thing I'm hearing through the lens of some of the companies I'm involved in is that some private equity funds are really nervous, those that sort of were rolling up dermatology practices, cosmetics, dentistry, things like that, have some debt on the books, and volumes have literally gone to zero in some of these practices. And so we're going to see the downside of private equity investment. On the flip side, some of those that are trying to build robust primary care networks, that are trying to move into managing chronic patients, may see this as a real opportunity to come in because there's still a ton of cash in these funds that it's being put to work. What I find interesting coming back to this again is those who went at this that were taking sort of PMPM models for chronic conditions and things like that. I really wonder how that's going to work. What was the reinsurance? What is the impact of COVID patients on that versus electives? We're going to learn a lot in the midterm about what it's like to own these practices and what the role of the health system is going to be versus these kinds of practices.
Steve, a multi-state system came to us this week and said, look, we're expecting a line out the door when this calms down of physicians who've, had no business or they cut their business by 70, 80% over a period of time. We're going to have to develop new criteria about whom we work with, how we assist them, bridge loans, technology, other staffing capabilities. It's causing us to rethink our clinically integrated network and what role we play. We're going to go to the payers and lobby on our behalf and on behalf of the physicians for some help on the rates. And we're probably also going to rethink our incentive comp structure to de-emphasize or to emphasize less the RVU percentage. We had started that approach already. I think that will accelerate, especially just given the reality of this year.
Interesting. Are you hearing any of I think there was a payer, maybe in Idaho, that was fronting the physicians 2 or 3 months of revenue. Are you hearing any of the physician groups, the large systems, helping out the physicians yet?
Only in discussions. I think for the moment, and on the day we're talking, I think is the day that the application's open for the small business loans. And they're trying to get guidance to the physicians that it's worth applying for those if you can, because if you maintain your staff, you can get that loan forgiven. For all we know, that website crashed first thing this morning. I think that was step one. And then there might be a reach out with, hey, we can give you some financial assistance in the near term, some bridge loans, something like that. I think it's all in play, but nothing specific yet, Steve.
Now, we've been hearing some really powerful, hopeful, emotional stories from the front lines, which by itself, I think is a silver lining to help rebuild the public image of hospitals and providers. But is there a bigger kind of healthcare industry level silver lining here?
It will. And I asked this of a COO last week, and his perspective was this will lend some urgency to some of the tough decisions we've been avoiding over the last few years. maybe that's what comes across. And of course, we're going to come out of this deeply appreciative of our frontline employees, nurses, physicians, techs, others, and we're going to need to find a way to celebrate that. We already knew there was a burnout situation in play. We really need to take that on firsthand. It's probably opened us up to new roles that people can play inside of our health systems beyond the current scope of practice. And that's a great lesson learned for our whole system that military medicine has reminded us of for years. Beyond that, we also should anticipate behavioral health needs of the workforce and plan for them, post-traumatic stress. Boy, there's a lot on the back end of this that it's going to require to get our workforce back to normal. And I know our chief nursing officers, chief medical officers, and CEOs are already thinking about that.
There will be a profound look back, I hope, after we get through the bolus of this. Again, we're coming into an election year, but I think regardless of party, this is going to reopen a discussion on a number of fronts. One is whether you're for single payer or some kind of opt-in, there will be a demand, I think, by the population of this country that healthcare be accessible. You may see more of a push towards an opt-in model, but I think it's going to be a pretty remarkable change across all voters that we need to do something to give people access to basic healthcare. Second, and this is something I've been an advocate of for a long time, it's going to put an incredible lens on administrative costs in the industry and the fact that we are focused and have been very focused on productivity of our front lines. And now we're seeing that the emphasis on that may have left us shorthanded. At the same time, you can't argue, because the data is clear, that administrative costs have ballooned. And I think that thinking about single payment systems, meaning we set rates nationally like a utility, everybody lives with them. We have a single set of prior authorization rules that everybody lives with. That's going to whack out 5-10% of the cost by the data that I've seen coming out of our clients and what they're spending on revenue cycle and these kinds of things. Number two. Number three, and I hope, as the parent of somebody who wants to be a healthcare provider, is we're going to see a profound change in how medical education works. We're not getting enough people into the workforce. They're coming out with too much debt and not enough people doing primary care, these allied providers. So hopefully we'll see a real change in how we think about medical education. And fourth, I'll limit the comment to the health systems, but it's probably more of a societal issue, is the nature of essential work. Our janitors, our housekeepers, our dietary service people that are making $12, $15, $18 an hour are putting themselves on the lines. Obviously, our nurses and doctors are as well. And the pay disparity, what we are doing for these people to take care of them, that is, I think, going to come to the fore. The healthcare systems that I know are all deep down extraordinarily compassionate. And I think there's going to be an evaluation of pay practices, wage scales, and how money gets spent in these health systems that I think could be an incredible example for the rest of the economy about how we think about who's essential and who does important work. But when the pandemic hits the fan, we know who's been on the front lines risking their lives.
That's really helpful and inspiring. So thank you both. And thanks to those listeners for joining us today. Steve, it was great to talk to you and hear from you again. And Bill, thanks as always.
Thank you. It's been a pleasure, and miss talking to the SG2 base, one of the brightest and most interesting group of people I've ever worked with.
Checks in the mail, Steve. Thank you.
It's true.
This has been another great episode of SG2 Perspectives, where industry experts and SG2 thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. Contact us anytime by sending an email to sg2perspectives@sg2.com. We'd love to hear from you. SG2 revolutionized healthcare demand forecasting with the Impact of Change forecast, and today, we're the industry's premier strategy advisory firm. To learn more, visit sg2.com. Thanks so much for listening, and we'll see you again soon.